So that was the effect of oxygen or the reoxygenation. First R, the second R is repair of the sublethal damage. So you need to understand the effect of fractionation on cell survival curve. We know the cell survival curve is the steepest when dose is delivered in a single fraction, which means that cells are most sensitive when dose is delivered in a single fraction. As the number of fraction increases, you can appreciate two changes here. One, shoulder reappear every time you add a fraction. Second, the curve gets shallower, and shallowness reflects the less sensitivity to the cell line, which means that fractionated radiotherapy is less effective in killing the cell. So to reduce the survival fraction to the same point or to get the same tumor control, you have to deliver increasing dose of radiation depending upon number of fractions. So we can say total dose needed for a clinical endpoint is directly proportional to number of fractions. And this is mainly because of repair of the sublethal damage. And this kind of damage is known as interfraction repair. And it usually completes in 4 to 8 hours. And if you look at the impact of this repair, it has got a positive impact on normal tissue because normal tissue will get repair, but it will have a negative effect on tumor because tumor cell will also be repaired. Now, this type of repair is not seen in non-fractionated radiotherapy because you are delivering the whole dose in a single fraction. So this type of interfraction repair is not seen, but another type of repair is seen that is called intrafraction repair. Now here the half-life is very, very short. And as we know, the treatment delivery in non-fractionated radiotherapy or in single fraction is very prolonged. It may be more than 40 minutes, 60 minutes, or maybe more than 60 minutes. But now with modern radiotherapy machine available, it is much faster. But usually it is delayed or it is prolonged. So what happens, how it affects the normal tissue? Now, this intrafraction repair will have the protective effect on late reacting tissue. As you can see on this graph that if the delivery time is increased from 1 hour to 2 hours, then biological effective dose will reduce from 80 to 70. So it has got a protective effect. So we can say that as the treatment duration increases, the bioeffective dose reduces for late reacting tissue. Not only this, but also the half-life of the repair. If repair is very, very fast, even the delivery time remains the same, it will reduce the biological effective dose from 80 gray to 70 gray. So we can say that faster the repair, more the loss of biological effective dose. So in relation to late reacting tissue, we can say that prolonged delivery of radiation in non-fractionated radiotherapy will have a positive effect on normal tissue. On tumor, what effect it will have? Negative effect. As the treatment delivery will increase, the survival fraction will increase. So it will have a negative effect on tumor. Now, if you really worried about the tumor control, and naturally we are, then the machine which can deliver whole dose faster are better as far as intrafraction repair in tumor cells are concerned. And that is why triple F beam is considered to be better than, filtered beam as delivery time is very, very short. So this was about the repair of the sublethal damage. Now let us just discuss about the third R, that is the repopulation. Now I have taken an example of non-small lung carcinoma. Now these two graphs shows the tumor control probability of NSCLC. Now this graph belongs to when there is no accelerated repopulation during radiation. This graph belongs to when there is accelerated repopulation during radiation. So if you want, suppose to have a 60% tumor control probability, then you have to deliver, say, 70 gray if there is no repopulation, but higher dose, say around 90 gray when there is a repopulation. So this clearly shows that repopulation has got a negative impact in tumor control, right? In lung cancer, it has been estimated that repopulation or accelerated repopulation start at 28 days. And we all know that most of the SBRT lung regime are completed by 2 weeks or even 1 week. So repopulation does not trigger in non-fractionated radiotherapy. In fact, this is the only R which has got an advantage in non-fractionated radiotherapy over fractionated radiotherapy. So that was about the repopulation. Then redistribution. So if you look at the effect of cell cycle on cell survival curve, we all know that G2M is most sensitive and the late S is least sensitive or most resistant. But we also know that during fractionated radiotherapy, cells which are in resistant phase will move to sensitive phase and become sensitive and will be killed, and this is called redistribution. What happens in non-fractionated radiotherapy? Because you are delivering in a single fraction, so there is no point or there is no question of redistribution. So how does it affect as far as tumor cell kill is concerned? Now we have two types of tumor, the benign tumor and malignant tumor. Now benign tumors are not actively dividing. So as far as the redistribution part is concerned, whether you treat with single fraction or multiple fraction, because they are not dividing, so there will not be any difference in sensitivity between the two types of delivery, that is non-fractionated and fractionated. But malignant tumor, certainly because of redistribution, fractionated radiotherapy has got an advantage over non-fractionated radiotherapy. So how we overcome this problem of, or how we overcome this disadvantage in non-fractionated radiotherapy? Now, this disadvantage is being overcome in a similar fashion like we just saw how we overcome the disadvantage of hypoxia. Now, again, try to understand. I said, or we discussed, that G2M is the most sensitive phase and S is the most resistant phase, and there is a 5-fold difference in survival after 2 gray. So, for most sensitive phase, if D0 is usually 2 gray, then for most resistant phase, the D0 will be 10 gray. And how much we deliver with non-fractionated radiotherapy? Usually more than 12 gray. So more than 12 gray will have a direct damaging effect on cells which are present in radio-resistant phase of cell cycle. So the problem is overcome in a similar way as we have seen how we overcome the problem of hypoxia, that it has got a direct damaging effect on the cells which are present on radio-resistant phase. So that was about the rationale based on cell survival curve, rationale based on 4 hours of radiotherapy in fractionated radiotherapy. Now, the next question is that is there any new radiobiology which gets triggered at such a high dose which we use in non-fractionated radiotherapy and which also contribute in cell kill? Now, so far we have seen that there are 2 processes of cell kill which are seen in fractionated radiotherapy and also in non-fractionated radiotherapy. That is alpha process and beta process. Now we have to see whether there is any other radiobiological process which get triggered, which also contribute in overall cell kill. Answer is yes, there are. And there are, how do we reach to this conclusion? We reach to this conclusion based on certain, experiment done on animals. Now, this is one such type of experiment. Now, here, the 1 centimeter volume of tumor implanted on the mice was treated with single dose of radiation with increasing dose, 10, 20, 30, 40, 50, 60. Now, if we presume that 10% of the cells are clonogenic cell in 1 centimeter volume tumor, which usually contain 10 power 9 cell, then number of clonogenic cell is 10 power 8 cells. So we need to sterilize these 10 power 8 cell in order to get excellent tumor control with single fraction radiation. Now, usually it's in non-fractionated radiotherapy. So this is the cell survival curve generated on laboratory. Now you see To get the 8 log reduction, you need 70 gray, even if you are delivering single fraction, based on this cell survival curve generated in laboratory. But usually we know that 20 or 30 gray in a single fraction result in excellent tumor control, which means, but based on this, if you look at 20 and 30 gray, it will just reduce 3 log reduction or 4 log reduction, which means based on this, survival curve, we should not expect an excellent tumor control. But in clinical setting, we are getting an excellent tumor control, which means that naturally some more process of cell kill also contribute when you deliver single high dose per fraction. Similarly, this experiment, again very interesting. Now here, what the authors did, they treated the mice tumor with increasing dose of radiation and generated the cell survival curve on day 0, immediately after, immediately on the same day when radiation was delivered, and after 5 days, right? So when same day the cell survival curve was generated, it was something like this. But when after 5 days we remove the tumor and generated the cell survival curve, the cell survival curve was much steeper, which means that the other process of cell kill also contribute in overall cell kill apart from alpha beta ratio. So these experiments clearly indicate that maybe some other process of cell survival kill also get triggered, and rightly so. It has been now well established that vascular damage and stem cell death also contribute in overall cell kill. So I will just discuss one by one. Now we know the vasculature of the tumor is usually aberrated. Vessels are dilated, tortuous, elongated. They have AV shunt. They have thin basement membrane. And if you look at the cell survival curve of endothelial cells of tumor and normal endothelial cell, this cell survival curve is much steeper, which means that tumor endothelial cells are more sensitive as the normal endothelial cells. There are enough evidence, preclinical evidence in literature, which suggests that when you deliver high dose of radiation, there is reduction in vasculature density, whether it is breast cancer xenograft or melanoma xenograft or ovarian carcinoma xenograft. There are a lot of evidence available in the literature. There are enough evidence, preclinical evidence, which suggests that when you deliver 18 gray high dose of radiation, apoptotic cells start appearing in the endothelial cell, which ultimately die and result into occlusion of the capillaries, which are not seen in control. And when you deliver low dose of radiation, that is 3 gray. This is another experiment which shows the effect of different dose per fraction on the vasculature. You see, when you give 2.5 gray, there is initial increase in the vasculature, but return to pre-radiotherapy level in 2 to 3 days. When you deliver slightly higher dose, 5 gray, it decreases after our radiation and remain decreased for several days. But when you deliver very high dose of radiation, the vasculature decreases very rapidly. Same thing here in this experiment, more recent publication, that when you deliver high dose of radiation, the end vessels density reduces when you deliver high dose of radiation, and this starts after 6 hours of radiation and will continue up to 72 hours. Same article also measured the apoptotic cells with increasing dose of radiation, and they observed that maximum percentage of apoptotic cells are seen when you deliver high dose of radiation, and this starts after 6 hours and continue after up to 72 hours. Now this is again an interesting experiment where 2 groups of mice were taken. Now one group of mice were altered genetically. They were altered genetically in such a way that apoptosis is blocked. So they become apoptosis incompetent. The other group are normal mice. They are apoptosis competent. Now these 2 tumors were implanted on these 2 groups of mice. the tumor were allowed to grow, and at this point a very high dose of radiation was delivered, that is around 15 gray. And what they observed that in apoptosis incompetent mice, the tumor continued to grow, while in apoptosis competent mice, there is a sudden reduction in tumor volume. Not only this, they also try to estimate the percentage of apoptotic cell with increasing dose of radiation. And what they observed that up to certain dose, there was no apoptotic cell, but after this threshold, there is a linear relation. As the dose increases, the apoptotic cell keeps increasing. So they concluded that there is a threshold for this third process, that is vascular damage, to get triggered. Now, what are the clinical evidences? Now, clinical evidences come from this article. Now, here the authors treated the metastatic brain lesion with single fraction SRS. And what they did, they first calculated the isoeffective SRS dose, calculated from linear quadratic model, and it comes out to be 25 to 35 gray. So if you concentrate on this cell survival curves, if you deliver 25 gray, it will reduce survival fraction to this extent, so that it translates into a tumor control probability of 80%. So this was calculated before treatment from the linear quadratic model. But when actually the treatment was carried out, they observed that similar kind of tumor control probability was observed at a much lesser dose, that is 15 to 20 gray. So which means, again, if you concentrate here, that if you give 20 gray, it should reduce the survival fraction to this point, translating into a TCP of 80%, which means that this cell survival curve should pass through this point, which means it should be much steeper. And this only can be done if there are more number of tumor cell kill as predicted from linear quadratic model. So this means that third process of cell kill also contribute, and we have already discussed there are enough evidence of vascular damage ultimately resulting into cell kill. So if you now study the cell survival curve at a high dose, now this is the cell survival curve obtained from linear quadratic model when two processes of cell kill are taking place. So if, again, to make the thing simple, if we just take an example of 15 gray, it should reduce survival fraction to this point, translating into a tumor control probability of 50%. So this is what from the linear quadratic model. But now we know that there is a third process of the cell kill also, that is the vascular damage. And there is a threshold up to which this process will not trigger, around 10 gray. After this only this process will be triggered and it will kill the cell. So it will reduce the survival fraction. Now this third process, if you incorporate in linear quadratic model, what will be the shape of this cell survival curve? Up to this point, no contribution by this cell process. So there will not be any change in cell survival curve. Now after this, it is also contributing in cell kill. So naturally the survival curve will become steeper, and in fact 15 gray should reduce the survival fraction to this point, translating into a tumor control probability into much higher what is predicted from linear quadratic model. And that is what we have seen in previous slide in our clinical setting also. So extreme hypofractionation result into endothelial apoptosis, resulting into vascular damage, hampered blood supply, and ultimately will result into cell death. So this is the third process of cell kill, and other two processes, alpha and beta cell kill. The fourth process is the stem cell death. We know that there are stem cells now in most of the solid tumors which are relatively radio resistant. So what are the evidence which suggests that there is a direct damaging effect of high dose of radiation used in non-fractionated radiotherapy to these stem cell? Now this evidence comes from this experiment. This is again a very interesting experiment. Deepak, can I continue for another 10 minutes?
Yes, sir, definitely.
Okay. So the last few slides. So this is again a very interesting experiment. Just try to understand. Now this is the jejunum villi of mice. If you look at the physiology, normal physiology of jejunum villi, at the base we have crypts. Now in crypts we have stem cells, which gives rise to progenitor cells, which gives rise to differentiated cell. And these differentiated cells are basically the functional cell which go to the villi, perform its function and die. And this process continue. Now, here the jejunum villi was irradiated with increasing dose of radiation. And what authors were trying to achieve? Now, when you deliver increasing dose of radiation, initially it will kill only progenitor cells, not the stem cell. So naturally, this will result into diarrhea, but it will be reversible because stem cell after some time will again produce the progenitor cells. But if stem cells are killed, then it results into irreversible diarrhea, leading to death of mice. So they were trying to achieve death of mice with increasing dose of radiation. What they observed basically, initially they observed that this increasing dose of radiation result into reversible diarrhea, but it was recovery took place and there was no death in the mice. When they further increase the dose and now the stem cells may be killed, ultimately result into irreversible diarrhea, leading to death of mice. But this damage to stem cell can be attributed to the third process of cell kill, that is endothelial apoptosis, vascular damage, hampered blood supply, ultimately leading to stem cell death. So we cannot say with surety that this was because of direct damaging effect of radiation on stem cell. So what authors did next time, they genetically altered these mice so that apoptosis is now blocked. And now they treat the mice with increasing dose of radiation, and they observe that up to higher dose there was no death of mice, but after this dose there was death of mice because of irreversible diarrhea. And now they can say with surety that in absence of endothelial apoptosis, there is a direct damaging effect of radiation on stem cells. And in fact, they identified stem cell population in the crypts which die at a very high dose. So this experiment suggests that there is a direct damaging effect of radiation. So if I just summarize based on the cell survival curve, the linear quadratic model, and other process of cell kill, then what are the process of cell kill at high dose of radiation? Two process, alpha beta, remains the same as we see in fractionated radiotherapy. Third process, vascular damage. Fourth process is stem cell death triggered at high dose level. So these basically are the four process. Now, one or two slides specifically for intracranial SRS. Now, how we get therapeutic advantage in intracranial SRS? Now, if you understand this curve, this basically single dose isoeffective curve for SRS. For example, if radiosurgery dose you deliver 20 gray, then it will be equivalent to 50 gray, 2 gray per fraction for early reacting tissue. For late reacting tissue, it will be 100, gray in 2 gray per fraction. So we can say EQD 250 for early reacting tissue, EQD 100 for late reacting tissue. So just keep this, this graph in mind while understanding the therapeutic advantage in intracranial SRS. Now let us take an example of meningioma. So basically, what is meningioma? Meningioma is basically a late reacting abnormal cells embedded in a late reacting normal cell. And naturally, both are late reacting, so both will have low alpha beta ratio. And we have seen in my earlier slides that when you increase the dose from D1 to D2, it causes more damage for late reacting tissue. So it will result into more damage to the tumor as well as surrounding normal tissue. So the question is how we get the therapeutic advantage. Two ways. One, by reducing the volume of red shell. Second, by creating a sharp dose gradient across the tumor. How? Just try to understand. So this is a meningioma. This is a late reacting abnormal tissue inside the late reacting normal tissue. Suppose you prescribe at periphery 15 gray. And if you remember my first slide, sharp dose gradient means this 15 gray will increase inside the tumor almost to 200%, around 25 to 30 gray. Now, if you come to this graph, 30 gray will result or 25 gray will result to an EQD2 of more than 150, almost 170. I mean, with any modality of fractionated radiotherapy, you cannot deliver such a high EQD2, which is possible with SRS. Similarly, if surrounding normal tissue, you see there is a sharp fall beyond this target. So naturally, this 15 gray will reduce, say, to 10 gray within few millimeter. Now again, come back to this graph. 10 gray, then EQD2 is just 25 or 30 gray. So such a sharp gradient, normal tissue getting just 30 gray EQD2, while the tumor is getting almost more than 150 or almost 200 EQD2. So that ultimately lead to therapeutic advantage. I hope you understand. So here I finish my talk by summarizing that the radiobiology mainly rely on technical innovation to deliver highly precise dose of radiation to target with minimal dose to surrounding normal tissue. There is a lack of repopulation, which is an advantage in non-fractionated radiotherapy. The negative effect of other radiobiological principles like hypoxia or redistribution, they are countered by direct damaging effect of large dose per fraction, which we have already seen, and new radiobiology not seen in fractionated radiotherapy are also get triggered at large dose per fraction, which we use in non-fractionated radiotherapy, and they also contribute in cell kill beside cell kill due to DNA damage. So with this, I finish. Deepak, over to you for any questions. Thank you very much.
Sir, thank you very much for a nice detailed overview of radiosurgery. Now, Dr. Shyam will take all the questions and will discuss one by one. I'll invite Dr. Shyam to start
Sir,
question answer.
sir, you were fantastic as always, and I think all the everybody, especially the DNBs and MDs, they would have benefited the maximum. So, there are few questions I want to answer. I want to ask. The first question is, what are the molecular and immunogenic markers of SRS SBRT tissue damage?
Basically, you see, there are when there is a mass destruction. I have not touched that because I was confining myself to the radiobiology only. So when there is a mass destruction of the tumor cells, there are the antigenic markers. They are released in the system. Ultimately, they invoke the immunogenicity inside the host, and this also result into contributing in cell kill not only at local site but also at distant sites.
Okay, sir. So, other question is, how does the SRS SBRT cause the abscopal effect?
This is what I just answered, that when there is a mass destruction, the protein molecules, they are suddenly released into the system, and these are circulated inside the host, and then the the immunity of the host take over these immunogenic proteins, and they get activated, which ultimately result into cell kill at distant sites. So it is basically a sort of immunogenicity which get invoked as a result of mass destruction.
Yes. So next question is from Dr. RK. What is the radiobiological reason for failure in SRS SBRT in GBM? He has asked.
So basically, we do not know exactly, how we can radiobiologically explain the failure. We actually accept, so maybe uh, uh, cells are really maybe very, very radio resistant, or, hypoxia may be another. Of course, radiobiologically, we know that it is overcome, but you never know actually when you are treating the tumor inside the patient with what's going on, what's happening. So, but right now we don't have any radiobiological explanation by which we can define why it gets failed.
Okay, sir. So next question, Dr. Sneha, she is asking why there is no CTB margin in SRS.
Okay, so basically, uh, one is that for benign tumor you don't have the microscopic disease, right? So naturally, you try to be as tight to the gross tumor volume as possible. Second, even if there is microscopic disease, so you basically prescribe at the periphery, right? Say 80% isodose line or less than that. So when the dose falls, of course, so dose falling, it take care of the microscopic disease around the tumor, because dose is very high given in a single fraction, right? So microscopic disease always require less doses as compared to the gross disease, right? And when you prescribe at the margin, say 80% isodose line, naturally if you are giving 20 grade 80%, so some microscopic disease when the dose falls outside rapidly, but still some of the thickness of the tumor or thickness of the normal tissue which is containing the microscopic disease will receive say 12 gray or maybe 10 gray in a single fraction. So that will have EQD2. If you calculate, it comes out to be the doses required for eradicating the microscopic disease.
Right, sir. So Dr. Faraz is asking, what is the relative contribution of vascular damage and stem cell death mechanism to the final outcome of
So,
SRS
so, so,
SBRT?
so, so we have not, the radiobiologists have not quantified so far. So we have not quantified so far. So we cannot say what percentage is by vascular damage and what percentage by alpha beta damage, or what percentage is by, because still we have to go a long way. Still we have to go a long way to understand the actual phenomena inside the tumor.
And Dr. Sunita is asking, why should chemotherapy not cannot be given concurrently during the radiosurgery or SBRT?
Basically, you see, uh, when we give chemotherapy as a sensitizer, so our aim is to improve the efficacy of radiation, right? So ultimately, we want to improve the biological effective dose. If I talk in terms of radiobiology, right? And usually, it is said that, especially in head and neck cancer, it is said that the biological effective dose equivalent to concurrent chemotherapy is around 8 to 10 gray, right? So ultimately, you increase the efficacy of radiation radiobiologically. Now with SRS, if you see, the biological effective dose is already so high, right? The EQD2, as you maybe more, is most of the time is more than 100 gray, 150 gray. So already you are delivering with your technology such a high dose of radiation. So there is no point in adding the chemotherapy. Rather, it will just add the toxicity of chemotherapy to it. And there is always, remember, there is always, if you look at the dose effect relationship, it is always a sigmoid shape. So after this steep rise, there is a plateau, right? So even if you increase the efficacy of radiation, it will not result into much improvement in tumor control.
Right, sir. And Dr. Asim is asking, what is the radiobiological impact of converting
I
a
think your voice
fraction
is
to
breaking. Sham, your voice is breaking. Can you repeat it?
yeah, yes, sir. Dr. Asim is asking the radiobiological impact of converting a single session SRS to multi-session SRS.
So basically, wherever it is possible. So idea is same, that you want to improve the therapeutic advantage, right? You want to improve the therapeutic advantage, especially in malignant tumor. If you give fractionated radiotherapy, maybe 2, 3, 4 fraction, the you can also harvest on the advantage of fractionated radiotherapy, like reoxygenation or repair of sublethal damage. So you can also harvest the advantage of this.
Um, Dr. Geeta is asking, which is the best prescription peripheral dose or prescription isodose? Is it a 70% or 50%? Which is,
I think
and
that depends, and this will be covered in detail in the subsequent lectures.
right. So I think, sir, we had a very wonderful presentation, and there are a lot of appreciations for explaining the radiobiology difficult topic in a very simplified way with graphs. So,
Thank you.
thank you so much, sir.
Thank you, Deepak.
Thank you,
Thank
sir.
you, Shyam,
Thank you,
and
sir.
convey my thanks to Dr. Tajen Kataria for having given me this opportunity. So thank you very much. Thank you.
Thank you,
Thanks a
Dr.
lot.
Gupta, and thank you, Deepak. Thank you, Sham, for the wonderful session, and thank you everyone for joining in. We look forward to see you again at the second session on 18th of November. Bye bye.
Bye bye.
Thank you. Thank you.